welcome to my presentation. I am Brianna Robinson. I am a BSN student at Midwestern State University. This is my capstone project that I did for this class. My project is about infant glycemic dysfunction and basically going over that journey from birth to home. So just a summary of what this presentation will include. We will talk about the purpose of this project, background and significant information about glycemic issues in infants, what I chose to be my PICO question. We will go over some literature review and then go into my proposal plan, which includes implementation, evaluation, dissemination, and then finally I'll just go over a summary of that plan, and I did have a slide for any questions. So just to begin, why did I choose to do this project? I work in labor and delivery as a full-time nurse. So I do see this and deal with this very often in my daily workflow. This proposal's purpose is just leading to identifying the issue of managing glycemic control issues in newborns, which is a fairly common problem that we do encounter. Ultimately, the ideal situation would be for these mothers to have perfectly controlled glucose disorders during their pregnancy, which would lead to their infant having perfectly controlled glucose after birth. However, that does not always happen, but when it does lead to them being able to smoothly transition into extrauterine life and be able to leave with their family in a perfect condition. So, a little background and significance about this project. So, during pregnancy, as everyone knows, the pregnant person is going through a lot of tests and procedures just to ensure that their pregnancy is going as normal as possible, and if any interventions are needed. In the case of this project, women do go through a glucose test or challenge, depending on who your provider is. Just because, in the case of this proposal, the issue of glucose management is one of the most common things in pregnancy to be abnormal. And then neonatal hypoglycemia is why we are doing that test, just because studies have shown that fetal hyperinsulinemia and hypoglycemia are significantly associated with the increase of neurodevelopment disorders such as ASD. So we do want to know if these moms are just predisposed to having an infant with any hypoglycemia or any type of glycemic issues. Later on in the project, I will talk about who those moms are, and even if those moms aren't at risk, sometimes after delivery we can tell which babies are at risk and who we should be testing more. So my PICO question: my population is newborn infants. I am looking at infants that were just delivered, usually those first 24 hours of life. My intervention is early intervention, whether this be skin to skin, breastfeeding, or dextrose gel if needed. We are looking at that compared to delayed intervention. Sometimes in the hospitals, it is not a priority to feed a infant as early as possible. So I was just wondering, how does that affect their glucose levels, which is our outcome in the first hour of life, if that is a priority, and if we do change that to making sure these infants get the intervention they need to help maintain their blood sugars. So first, just going over some literature review about the subject. We have one study that looked at non-pharmacological prevention of neonatal hypoglycemia. So that would be skin to skin, breastfeeding, things like that. They did focus primarily on using breastfeeding since their skin to skin method wasn't showing any sufficient data, and they did find that using breastfeeding as a prevention method did increase that infant's likelihood of having normal glucose levels. And then we looked at another study that looked at early intervention of skin to skin combined with breastfeeding. So, not looking at one or the other, but looking at both of them combined, which did significantly increase the early blood glucose of newborns with GDM, which is a gestational diabetic mother, which effectively led to decreased rates of neonatal hypoglycemia. And finally, another study looked at glucose gel implementation with breastfeeding. So, that is basically a sugar gel that sometimes we can supplement with infants that have hypoglycemia. Um, this study looked specifically at just introducing that gel with breastfeeding early on and seeing if that helped decrease rates of hypoglycemia, which they did find that the introduction of 40% oral glucose to the protocol, which is breastfeeding, helped the safe management of asymptomatic hypoglycemia and at the same time implemented breastfeeding. This also decreased NICU admissions and need for IV glucose, which would be a higher level of care and could lead to a longer stay in the hospital for that newborn. So, my proposal plan is looking at how in newborn infants, how early intervention within that first hour of life would impact their glucose levels as compared to delayed intervention in the hospital setting. On the screen, you can see kind of a typical protocol for testing these newborn infants that we know are at risk. Um, I was just wondering, like, a part of my plan, what if we made it a priority to just have early intervention instead of waiting on that point of care testing to show that this newborn infant already has hypoglycemia and trying to basically catch up with their blood glucose levels. All right, so implementation. My implementation proposal would start with introducing more of like a flow sheet for labor and delivery nurses to start and to follow that baby into mother baby or NICU as whatever care is implemented for that child. In accordance with that flow sheet, I would want to know, do we know if this mom is already at risk? So, some at risk moms, if they have any type of sorry, if they have any type of diabetic disorder, so that can include type 1, type 2 diabetic moms, if those moms who are just only gestational diabetics, we would already know that their newborn is at risk for being hypoglycemic after birth, so their newborn would already be tested. And then we would want to look at some risk factors after delivery. So those would include, for most hospital settings, we're looking at this baby size. So is this baby large for their gestational age, or is this baby smaller for gestational age? Research has shown that those babies are at risk for having hypoglycemic issues early on, so they would be tested. Another risk factor would be that baby's gestational age. Is this baby above 37 weeks? Is usually the cutoff for most hospital systems to say, okay, I don't think we need to check their blood sugar. However, if they are under 37 weeks, it is mostly a standard to check that baby's blood sugar just because preterm infants are shown to have increased levels of hypoglycemic disorders. So, in following with that implementation plan and testing those at risk moms, we would need to document what our early intervention is and how how long into life did we implement that early intervention. So in my project, I did say early intervention can be any type of feeding, so breastfeeding, formula feeding, donor breast milk, whatever is available at that hospital, just some type of feeding within that first hour of life should be prioritized for these infants. Um, and then also, if there is any gaps in why that can't happen, such as maybe this mom is needing a higher level of care, or maybe baby is needing a higher level of care where they are separated, that is would be a limitation to this project. Or if for any reason, if baby has any feeding issues or anything like that, that would be a limitation to this project. Um, so, this data would be collected for about 6 months just to account for those gaps and those limitations, just so we have a good number to go off of. Evaluations. So, I would expect that early feeding would lead to glucose homeostasis in these at risk infants and ultimately decrease their hospital stays and need for higher level of care and interventions. We would expect to see that NICU admissions would decrease just because these babies wouldn't need to go to the NICU to have IVs placed or have higher levels of care for their hypoglycemia. The same limitations would still be presented in this phase just because maternal and newborn separation of any kind would be accounted for in while we're implementing that data. So dissemination, how would we get this proposal plan out to the public? Couple of routes that I can think of is AWAN, which is our nursing organization specifically for OB nurses, neonatal nurses. Um, just going to your local chapter meeting, I could propose this plan just to kind of get the evidence out there and just kind of it's more of a starting ground more than very much changing protocols or policies. Recertification classes. So there are a couple of things as OB nurses and neonatal nurses that we need to know that we are supposed to be certified in, such as neonatal resuscitation and things like that. Just presenting that information in these classes would be a good way to get that information out. And then also just national conventions. I know A1 does do more of like a research presentation block where you can kind of go around and look at what different hospitals are researching and changing as far as their policies and protocols. So that would be a good way to get this information through. So, a summary of this plan. This plan is, like I said, a great beginning into trying to solve a common problem. This can ultimately lead to bigger complications and patient outcomes. Neonatal hypoglycemia, like I said, is a very common problem that we see in those first few hours of life, which most hospital settings do have a good policy and protocol on how to handle those at risk. I would just believe sometimes we need to implement feeding and just earlier intervention just to decrease those numbers as much as possible and to lead to a smoother transition into life, extrauterine life for these babies and a smoother transition for this new family also. And that is my presentation. Please leave me any questions or concerns or comments. I greatly appreciate them. And thank you for listening to my project.